supporting a statewide and one day we hope sustainable CHW infrastructure. He's also a physician practicing part-time at Weill Cornell and the Lower Manhattan Hospital in New York City. I know it well from my time living there. Devin, thank you so much first for joining the 160 plus participants today, and just take a moment please and share what you will on behalf of your colleagues and CHWs across the globe on the impact of Dr. Farmer.
Thank you so much, Denise. And wow, I feel like you did such justice to his voice, his legacy, the advocacy that Paul created, and what he tried to instill in the organization of Partners in Health, which was founded to provide a preferential option for the poor, and was really rooted, and the core focus of the work has been really rooted in communities, serving historically and actively marginalized populations around the world, and the core workforce that has supported and been crucial to all of that work. Again, we're not coming late to this game, 30 plus years into it, and from day one, community health workers have been at the center of that work. So I'm honored to be invited here by you, Denise, by Romana, Abdullah, other partners and collaborators in North Carolina. Shout out to Honey on the call. I see all of you. Thank you so much for your support, your collaboration. Paul transitioned unexpectedly in late February, and I think all of the Partners in Health family is still reeling from his loss. This may be the first time I'm talking about it where I'm hoping I don't continue to tear up, but it's been a hard process for all of us. Paul in 1987 started, and his friends, it's important to remember that he didn't do this by himself. Nothing that he did was possible without such a wide network of friends and collaborators. They founded Partners in Health in the Central Plateau of Haiti in 1987, responding to what was a failure of imagination in terms of responding to HIV, to tuberculosis, to thinking that health systems could not be developed or sustained in a remote, impoverished place that had been through turmoil over decades and centuries. And they sought to turn that on its head. And I think Paul was a co-founder of PH, a visionary, an advocate, a teacher, and a doctor. And in all of these roles, he partnered with so many people to grow this organization, to stay true to that mission. Today, Partners in Health works to strengthen public healthcare systems in 12 countries across 4 continents, really still rooted back in the Central Plateau of Haiti, partnered with the Ministry of Health. So important to work across kind of public sectors who can ensure that right to health and to healthcare and enforce that right to health and healthcare. And he touched everyone in the PIH family and so many more around the globe, patients, students, drivers, cooks, so many more who counted him as a friend, and somehow he was able to connect with, and he had you in his WhatsApp, even if he met you once or like talked to you regularly. And it's mind-boggling how many people he was able to maintain those connections with. And that personal connection is something that still rings so strongly to me, and why kind of communities are at the center of Partners in Health's work. And I think he inspired so many people on their career path through his writing, through their connections to him. And I know personally back 15 years ago on this journey, why I went into medicine, why I worked before and still work for Partners in Health now. And it's really impossible to sum up what the loss of Paul means as a person. But I think the tens of thousands of us who now count ourselves part of Partners in Health around the world know what he wanted. I think, as Denise mentioned, that was dignified, high quality healthcare for all, no matter where you were born or where you live. In PIH speak, that became a preferential option for the poor. And he left us a roadmap. It was expand your circle of empathy, show that complicated things are possible, and above all, think of each patient as a member of your own family. And finally, be bold when you imagine a better future. Do not be constrained to the boxes or structures that have been set before us. As a teaching physician, medical anthropologist, so many of his writings and ideas like accompaniment or structural violence or social justice or equity spell out the way forward in detail. And these, in fact, weren't even his ideas or phrases, but he gave them voice and elevated them into the public discourse in a way that now I find that they're very commonly discussed and people understand and know the words equity. And I know he played a small part in that, but but I do thank him for playing at least that small role. And I really do want to mention that community health and community health workers have been at the center of Partners in Health since the beginning. And I take that back to that model of accompaniment, which is walking hand in hand with someone along their journey. And I think a big point of Paul's was that accompaniment and the timing of accompaniment wasn't determined by a doctor, a nurse, a community health worker in terms of when that journey stopped. It was actually determined by the individual receiving the accompaniment when they said, my journey is complete, your work and your support of me is done, and rooting back to the individual, to the patient who is being served. For Paul, understanding community, being place-based, having lived experience, was so important to understanding and responding to the needs of vulnerable communities and populations. And to me, that is what PIH embodies, and it's why I'm so happy to be here talking with you all today, because so much of what PIH stands for, so much of what our strategic plan is, and the work that I really want to see happen really focuses on elevating and championing community health workers as key members and leaders within public health, and community systems. There have been challenges throughout all of this work, but as Paul once said, I think to so many of us, that's the whole point of working in partnership, of doing hard things with people you care about. I think within PIH, there's always someone to lean on to move things forward. There are now over 18,000 of us, so many more allies around the globe. I think Paul's legacy is carried on by our CEO, Sheila Davis, co-founder and chair of the board of directors, Ophelia Dahl, our chief medical officer, Joya Mukherjee, among countless others, from site leads to drivers, from nurses to physicians to community health workers. And I feel that kind of drive forward that we all carry on Paul's legacy. So I really appreciate the opportunity to share a little bit of this reflection with you all.
Thank you very much, Devin. You know, I want to say you started preaching there when you started talking about the individual getting a chance to determine when those services end. I see that resonates with some people. You know, when we talk about sustainability for our profession in the United States, we have a number of barriers, but one of them is the identification of CHWs as professionals, right? As others are professionals, and allowing the connection between community members who understand their needs and barriers and want the services of CHWs. We need to bring those structures, those funding models forward, not only in Medicaid, but across all of our systems. So we have a long way to go across the globe, but certainly here in the United States. Well, I want to again thank you, all of you, for joining us. We've got almost 170 folks, and I've got one more introduction to do, and it's my great pleasure right now to introduce Ashley Rodriguez. I just want to say this is my sister from Texas, because that is absolutely how she greeted me when I became a new executive director in November 2019 of NACHWA. She has been a partner, a thought partner and leader. She has been my ally and compadre as we help to build the community-based workforce alliance. She has helped to strengthen and amplify the National Association of Community Health Workers through her leadership role at the APHA CHW section. And I just want to take a moment and thank her. She is also in her leadership role at the Texas Association of Promotores and CHWs and at Baylor Scott and White. Just a tremendous servant and always desiring to give. You know, Ashley is a CHW and CHW instructor with over 14 years of experience in community and public health. She's currently the Community Health Worker System Manager at Baylor Scott and White Health System, as I mentioned. In her current role, Ashley is responsible for promoting and driving underserved and community health focused projects, as well as to develop new and innovative program applications for community health workers. She serves as the APHA CHW section chair, and she's a founding member and currently serves as the president of the board of directors for TAPCHWA, the Texas Association of Promotores and CHWs. Ashley's passion is to build partnerships that support, promote, and elevate CHWs like myself, as well as teach continuing education to CHWs across Texas and nationally. And it is my great pleasure to share this day with you. Thank you again for helping to develop such a fantastic event. And Ashley, the mic is yours.
Thank you, Denise. You always give me warm fuzzies. You're so sweet and so kind. I'm honored. Hey, everyone. So I'll try not to take up too much time. I'm really just here to kind of give some background and then turn it over to our illustrious presenters. APHA has played a prominent advocacy role on many public health and community health focused issues, often generating impactful policy. Since 1872, APHA has continued to search for and support those policies and practices that are most likely to improve the health of the public. APHA founders very early recognized that two of the association's most important functions were advocacy for adoption by the government of the most current scientific advances relevant to public health, and public health education on how to impact community health. And the CHW Section Policy Committee convenes together with CHWs, allies, advocates from all over the US and arguably sometimes globally as well, to develop and support APHA policies that promote the CHW workforce and to identify and share best practices to further advance institutional, local, state, and national policies that support the community health worker workforce and, more importantly, self-determination. As many of you probably already know, our 2001 policy statement on recognition and support for community health workers, contributions to meeting our nation's healthcare needs, that initial policy, and then in 2006, we took that policy a step further by submitting a request to for a classification for community health workers to the Bureau of Labor Statistics for inclusion in the Department of Labor's Standard Occupation Classification Revision of 2010. The request was well received, and in January of 2009, the Office of Management and Budget officially published the 2010 standard COS or SOC, which includes unique occupational classification for community health workers. And all of this is outlined in our 2009 APHA CHW section policy, which is titled Support for Community Health Workers to Increase Health Access to Reduce Health Inequities. This particular policy is the one that is often cited with the official definition of the workforce. So many of you are probably very familiar with that policy, but I had to touch on those other key drivers that have really helped to inform the workforce nationally. I also have to note, for those of you that aren't familiar, a lot of what NACHWA is ultimately also grew out of and exists today from work from former leaders from the APHA CHW section. There are folks that have been involved in this work since the 1970s, y'all. I also share all of this not only to provide a brief history of the section, but also to demonstrate the power that the policies that come out of the section, how powerful they can be. And the policy you're going to learn about today is for CHWs advancing racial equity and violence prevention. This policy has been worked on tirelessly since January of last year. And it goes without saying, I also have to highlight the amount of work that has gone into this policy by Ramana, Abdullah, and Angie, including the countless meetings, probably tens of thousands of emails, no joke, and truly grassroots outreach efforts to garner endorsement support from not only APHA sections, other sections like maternal and child health, but also key organizations with reach like NACHWA and Partners in Health. And by working with CHWs, CHW allies, and various advocates, these policy co-chairs have put together a comprehensive policy proposal that outlines a strategy to address racism and violence as public health priorities. This policy truly aligns with the CHW profession, and if adopted, will further support a multitude of organizations in their efforts to advance racial equity, and also to hone in on how CHWs can continue with our impact by being the local level advocates that can provide education, outreach, and to help further impact violence prevention at the community level. I'd also just shamelessly like to invite you all to get more involved with the APHA CHW section. You can get involved by submitting an abstract now. The timeline is they're due through April 30th. And of course, by joining any of our committees, including the policy committee. I'd love for all of you to become paying members of APHA, but I know that's not always feasible with budget cuts and all kinds of things. And maybe your organization just is not truly, quote, a public health entity. But you can still get involved with our committees. Angie's going to plug in a link here shortly where you can learn out more. And you can also reach out to me directly if you have any questions about getting involved with the section at chw.chair@apha.org. And now, without further ado, I know I speak really quickly, so I'm hoping there's transcription or you can watch the recording later. I also just don't want to take away from the true content and the purpose of today. So I'm going to turn it over to Angie Kuzma, who's also one of my colleagues/sisters. She's not only APHA CHW section policy committee co-chairs, but she's also the Nashua Network Policy and Advocacy Manager. Angie was previously the Policy and Data Manager at the Oregon Community Health Workers Association, also known as ORCHWA, and has over 12 years experience in public health. She recognizes CHWs from all levels of experience as natural leaders and policy analysts. She believes CHWs' innate qualities and skills are essential in order to create a more just society, one that promotes health and racial equity by institutionalizing anti-racism. Angie, I'll turn it over to you.
Oh, thank you so much for that warm welcome, Ashley. Yeah, so as Ashley mentioned, I'm a community health worker here in Portland, Oregon. I've been working in service to people experiencing homelessness for about 10 years in total. That's the shared lived experience that I bring to the profession and to advocacy for the profession as I experienced homelessness as an adolescent. So I'm also, I've had the great privilege of co-chairing the APHA CHW section policy committee alongside Rumana and Abdullah, who I'll give proper introductions to in just a moment. They're two esteemed colleagues of mine who I have just the utmost respect, admiration, and gratitude for. Over the last several years of working together as a team, I've been witness to just the incredible effort that especially the two of them have poured into this policy proposal. And it's hard to even put into words just the amount of work. Hard work comes to mind, but it's that phrase kind of comes up short for me in terms of what I've witnessed in this process. So I really think that what they put into it is love for their communities and all historically oppressed and other marginalized peoples, love for CHWs throughout history and today, and love for the CHWs of the future, and really those foundations and origins of the CHW profession as one that works to prevent the multiple forms that violence can take. And I know the three of us really want to see that not as something that's in the past, but something that's maintained and really valued today about community health workers and continues on into the future. So without further ado, it's my honor to introduce Rumana Shams Rabbani and Abdul Hafid bin Abdullah. Rumana was born in Dhaka, Bangladesh, one of the poorest and most populated countries in the world. She was exposed to severe lack of chronic social and health security that included witnessing poor mothers and their children dying on the streets of Dhaka. As an immigrant to America, Rumana's life experience sits at the intersectionality of an immigrant woman experiencing racism and a survivor of domestic violence. Rumana received her master's degree in health administration, focusing on strategic management. She's currently a doctoral student in the Health Policy and Management Department, minoring in implementation science at the Gillings School of Global Public Health, University of North Carolina at Chapel Hill. Rumana is also a Robert Wood Johnson Foundation Health Policy Research Scholar. She is one of the three co-chairs of the APHA CHW section policy committee, and she serves on the policy committee for the Community-Based Workforce Alliance. Locally in North Carolina, Rumana is the chair for the North Carolina CHW Association, and she's on the advisory board for Sakota House, located in Wilmington, North Carolina. As a co-founder of Community Healing and Activism through Strategic Mobilization, or CHASM, Rumana advances racial equity and uplift CHW culture within North Carolina's statewide CDC COVID resiliency funded initiative. Rumana really does, I don't understand how she does it all. She's one of the most involved and busy people I know. And again, I feel just really lucky to work alongside you, Rumana. Abdul Hafid bin Abdullah was born and raised in San Bernardino, California during America's war on drugs and mass incarceration era. Abdullah first experienced incarceration at age 9, and by age 17, he was sentenced to prison as an adult for 8 years. While incarcerated, Abdullah was inspired to shift his worldview and began to tenaciously pursue a journey of self and community healing and restoration. In 2011, Abdullah was introduced to the CDC-funded Multnomah County Health Department, striving to reduce youth violence everywhere, or STRIVE. And that's actually, Multnomah County is where Portland's located. And I've also worked for the Multnomah County Health Department. So he and I are connected in that way as well. Abdullah co-led a successful implementation of the STRIVE program. And in 2017, he adapted and began to implement a community-centered and community-driven version of the STRIVE program inside North Carolina Cape Fear region, now titled a Community-Based Public Health Response to Violence. Abdullah is the Executive Director of Quality Life Blueprint and the founding Executive Director of Sakota House, which is a cultural hub and community development center in Wilmington, North Carolina. He also serves as one of the 3 co-chairs of the American Public Health Association Community Health Workers Section Policy Committee, and he's a board member for the North Carolina CHW Association. As a co-founder of the Community Healing and Activism through Strategic Mobilization, CHASM, Abdullah advances racial equity and uplifts CHW culture within North Carolina's statewide CDC COVID resiliency funded initiative. Again, I'm just beaming with gratitude to work alongside you and to be a part of this process. Without further ado, please take it away, Rumana and Abdullah.
Thank you, Angie, Denise, Bernadine, Devin, Ashley. Thank you guys all genuinely and sincerely for your poignantly executed, transitions, right? You guys did an excellent job. Really honored to be your colleagues. And also just to be aware, guys, so Angie will actually be in the chat. So if you have any questions, if there's any opportunities that you're thinking you may have to leave early and you're interested in learning more about, potential implementation of this particular policy, maybe you learn something that you feel like is exciting for you, you want to plug in, or if you're interested and you have a question, right? Leave that inside the chat. Or she's gonna put in a link for a Jamboard. In that Jamboard, you can kind of put your message in, whether it be conversation around implementation, whether it be you have a question, or anything that you may need. And then what Angie's going to do for us, guys, is take all the questions at the end of the actual session. She's going to synchronize those questions and lead us inside of a Q&A. And then once we finish those, if there's still time, we'll open the floors for conversations and comments. Go ahead, Sister Rumana.
Thank you, Abdullah. I'm honored and I'm grateful and I'm a little bit speechless. Like Angie, your introduction made me nervous because you set the level so high. So thank you so much. I've known Angie for so many years. Ashley, I've worked with her. Denise, I want to thank everyone, Devin, Evan, Honey, all of you that are here. I'm going to go ahead and share my screen so we can get started. Okay, so today we're talking about our policy proposal during National Public Health Week. Again, I want to thank Denise and Ashley for coordinating this, uplifting the policy proposal, community health workers advancing racial equity and violence prevention. So I'll go, and as we've said, Angie will be facilitating. And so this is an overview of the agenda. We're going to go through the process for the policy, history of community health workers and racial equity, policy proposal itself, endorsements and implementation, discussion, and Q&A. So before we go into the policy proposal, the participatory process. We really want to thank the team of people. We have worked extensively, but we have a group of people that have helped us to get this policy proposal and move it forward. Without the team of people, we couldn't do this. And so I just wanted to acknowledge the key authors, includes, Abdullah, myself, Danny, Dr. Williams, Keela Marlin, Dr. Noel Wiggins, contributors, Angie Kuzma, Dina, Charlie, Honey, Jamie Santana, Maria, Ashley Rodriguez, Justin Mendoza, Devin, Brenda Galloway, Vance Williams, Kashana Owens, Cody, Evan Richardson, Dwight Myrick, Juliet Jenkins, Ashley Winterstrom, Teresa Campos Dominguez, Jennifer Norville, Majelyn Begay, Maria Valesco. And we wanted to give special acknowledgements to Betsy and Raphael at the CDC. And also APHA endorsements so far. We have endorsements from public health, social work section, oral health section, and breastfeeding section. And we are also have other sections that are planning to endorse once edits are made. So external endorsements include Partners in Health, Community CHW Common Indicators Project, Community Healing Through Activism and Strategic Mobilization, North Carolina Community Health Worker Association, and North Carolina Area Health Education Centers. Really want to give a shout out to Honey and Evan, who have been beating the drum really hard on racial equity and community health workers in our state in North Carolina. So I'm going to go through this kind of rapidly because we have pretty dense slides. And so just to illustrate to you that our community health worker section at APHA has used a participatory process that included community health workers and community health worker allies throughout the country, starting in January 2021 to this final submission in February 2022. And that included numerous breakout rooms. We met for a year and a half and late nights staying up and writing this policy proposal and getting it together. We finally submitted in February 2022, the final version. It got approved by the JPC co-chairs, joint policy co-chairs of APHA. It is now out for public viewing, and Angie will drop the link in. And again, repeating what Abdullah said, when you get the Jamboard, if you're interested to be an external endorser, please put your name, email on a post-it in the Jamboard, or if you'd like to implement the model that we'll be discussing. Thank you. I'm going to pass it on to Abdullah.
And I'm gonna start by putting myself on the timer because I'm gonna have the honor of actually, and also the challenging task of talking about one of my more favorite subject, which is historical context, right? I don't believe you can ever get to equity without, prioritizing that from which you've come, making the connection to the current conditions, and then comprehensively exploring with all that information, how to actually come up with solutions, right? So in order for us to talk about systemic racism, right, or any other form of systemic oppression, we have to talk about the origins of our country, right? And I want to create a space where, because I know I'm kind of preaching to the choir, right? But the purpose of actually giving this information to you is to kind of like synchronize our minds and our hearts around the objective at hand, right? We're calling, here's this document that's going to be put out here, and we're hoping it's going to do something. It's not going to do anything unless we ourselves grab it and do something with it. So we want to bring, right, the proper type of actual ingredients into the room to do so. So we're first to start talking about, we know in 1493 average time, the Spaniards, came here to Central South and what they refer to today as North America. We know at that time, this is a whole civilization of people, well-established, very cultured, very sophisticated in the way in which they connected to the earth and they connected to this particular land here. But individuals decided that they wanted to come to this space and they wanted to actually dominate and then exploit what they can from those populations of people, right? That's the first thing to note, right? Is coming into the inception of this concept of America, individuals came to this space and they had the objective to dominate and to exploit. Well, eventually from the Spanish to the Portuguese and then to the Anglo-Saxons, all of Central, North, and South America is actually, occupied and colonized. By, I would say, mid 1500, there's this ingenuous ideal that in order to build the country, they're going to need some more support. So they began to go into the lands of Africa and extract the populations of people from there, right? And bring them over to what we know today to be Americas as actual slaves. And this is a different type of slavery that I think is going to be important for us to note, that this type of slavery literally defined the populations of people as less than human. Not only did they define them, there was chattel. In many cases, there was being treated even less than the conditions of animals, right? Where animals are taken care of and treated, especially in South American culture, in a very hospitable way, where many of the slaves were not. They were treated, almost to the point of being, driven to work to death and terror different capacities, right? So it was this mindset of, I have the right to treat you this way because I don't necessarily consider as equal to me as a human being, right? Over anywhere from, 10 to 12 million human beings on average, right? And we don't want to go into the details of that, but many of you guys have heard that history. Keep it on the front of your mind, right? The forefront of your mind. Well, inside of 1776, our country established itself when it chose to actually declare itself independent of the British, they refer to their British colonial powers, right? United States of America, they was also a colony in a certain sense, where they was an extension of the actual British Empire. And because of taxation without representation, right? Because of what they defined as actually being treated unjustly, even to the point where Patrick Henry declared, give me liberty or give me death, right? They determined that they was willing to actually fight in order to have their sovereignty, to be able to be treated as full human beings and actually be respected as human beings. So they fought and they won. They established the United States of America. When they established the United States of America, though, it's important to know that the first article, the second section, right, it defined anyone that was not a European male, right, as only 3/5 of a human being. This was actually encoded in the law, right? This is important because we're talking about systemic racism, right? So we want to be able to make it, where's the root, right? Inside of our law, which then governed our whole system, we said legally, right, which therefore justified morally, these human beings were not completely human, only 3/5. So we know the story, things continued on, slavery continued to advance. And at some particular point, it became internationally unacceptable. People was pushing against slavery. United States of America, and I believe Brazil was the last ones to kind of hold on to this concept of chattel slavery. International pressure, right? Maybe the advancement of industrialization, a lot of different reasons. Nonetheless, it created a circumstance where the United States of America hit a crossroad, and the federal government determined that the South needed to actually end its actual practice of slavery as a primary source of economics. So a war ensued. Our country went to war with each other. Fathers and sons killed each other, man. Blood was shed. It was a very, I guess, in the sense of the intention, if it was really to end slavery, it was a very noble time in our history because we fought to become better people, right? Unfortunately, though, once that actual time came about to be able to say that we actually really ended slavery, we decided that the actual law that was going to be put in place that would give us the permission to say, or give us the actual ability to say that we ended slavery, we ended the dehumanization, the legal dehumanization of other humans. We passed that law in 1865, and that was the 13th Amendment. And the 13th Amendment states, I quote, neither slavery nor involuntary servitude, except as a punishment for a crime, right? Except as a punishment for a crime, wherever the party shall have been duly convicted shall exist within the United States of America. So again, I don't care if they would have said, except for having blonde hair, except that you got a big toe, except for that you wear a certain type of clothes. When you give yourself an exception to say that I can still enslave you, right? And slavery is based off this notion of dehumanization. We then are able to pinpoint the actual roots of some of the behaviors that we're dealing with still to this day. So moving forward, we got the Reconstruction era. African Americans, again, we're talking about the African American, not in exclusion to the indigenous populations, because I understand indigenous populations dealt with a parallel condition. We're just using the African American as a case study. So Reconstruction era, after 300 something years of slavery, you have 10 years of a period of time in our history where African Americans began to thrive beyond unprecedented examples, right? They became business owners, they became politicians, they became scientists within this particular period of time, 10 years, so much so that organizations and institutions start being developed in order to inhibit their growth, to literally, if they need to literally, by way of terror, take their opportunities away from them, right? So the KKK, Ku Klux Klan, and various other entities was created with the specific design to inhibit the growth of African Americans. So we have that period going up into 1877, and then from 1877, and then from 1877 to 1964, you have what they refer to as the Jim Crow era. We're talking about separate but so-called equal, not equal. We're talking about over 40,000 recorded lynchings. We're talking about whole cities like 1898, Wilmington, North Carolina, massacre / coup d'etat, where they went in for 2 days, killed 200 something plus people, went door to door, made people remove their actual, sign their homes over, sign their businesses over, made the actual sheriffs and various other public officials step down from political office. Or Tulsa, Oklahoma in 1920s, where they really went in and killed and murdered, individuals and tucked the wealth away from the actual Black Wall Street. right? This is during the period, right, of Reconstruction era, or the period of Jim Crow. Now, you have the 1960s, 1950, 1960s, and you have a period of time where African Americans are thriving because social justice becomes something that not only African Americans, but Latinos and indigenous populations and even white Americans are determined is a need for change. So our decided to execute an actual objective of the COINTELPRO to actually eliminate and to actually harm and neutralize what they refer to as social justice organizations. They used the first war on drugs in the 1970s to be able to target these social justice organizations, identifying heroin, marijuana, and identifying psychedelic drugs within the hippie community as a way to neutralize those organizations. Why is all that history important? Leading up to that point, why is all that history important? One, because from the time of slavery up until that period of time, you've never seen a case where there was so much interpersonal violence and interpersonal trauma bleeding out within the ranks of African American communities. The family structures remain strong, right? The connections of transgenerational knowledge and actual respect for the elders remain strong within the African American community. Resiliency was present, right? Health was still present, even though there was lack of proper access to health. Something changed. Please, next slide. This is how much time I got. Okay, get a video real quick, please. I'm sorry.
That's okay. I'm hoping I can get the sound to work. So
You should be able to. We're gonna say this one now, you will. Just click it.
And my car is dented.
Geico does offer
Sorry,
24/7
everyone,
claim service.
24/7, that's a lot of attention.
They're not actually with you 24/7. They're just available whenever you need them.
Okay, because I'm an introvert. It's incredibly rare.
I don't think that's right.
Geico. You know how they say that everybody has a purpose in life? Well, at one time I felt that selling cocaine was my purpose.
We was starving, just looking for a way to succeed.
The first time I seen rock cocaine was 1980. Murder rate was sky high.
South of the 10 freeway was kind of a no man's land.
So, you know, we're selling it to the blacks. So you go into these neighborhoods, there's no cops, you can sell it where you want, and when they start killing each other, nobody cares.
I was going through like $1 million worth of drugs just about every day.
That's like gold. We can make a fortune.
He was maybe the biggest guy in LA.
Rick, Freeway Rick.
Freeway Rick was getting his dope from a very big operator. I think we're into something that's bigger than us, something we really can't deal with.
They had been trafficking on behalf of the United States government.
She could prove what she was saying.
The story was mind-boggling.
When I was young, let me tell you how it was where I come from.
As I've said before, no drug network will remain alive.
There's a lot of people who think that, you know, I made that whole thing up. What they don't realize is that the CIA admitted it.
See, I didn't know until I was sitting in prison how valuable an education was.
Yeah, drugs suck. Drugs are really bad. But the drug war is worse.
You want to know a version of hell? Be the only guy playing straight in a dirty card game. And that's what the drug war is.
There are more people in prisons and jails today just for drug offenses than were incarcerated for all reasons in 1980.
Me being here is defying all odds. People don't get federal life sentences and beat them.
We've been spending billions and billions and billions of dollars every year on this war on drugs to find out that the government was involved. That's pretty astonishing.
Crack in the system.
This is Los Angeles. Even if the government just turned a blind eye and didn't do anything about it.
Okay, so again, just making a connection. So again, leading all the way up into this period of time, you have, you know, these externals of actual terror that's being inflicted upon African American communities and other populations, right? But never in our history, as far as what's here in America, had you had certain cases of such interpersonal violence and interpersonal self-inflicted harm, right? And this is the point we want to actually make a connection to, because something took place in the 1980s, but first we want to prove the case real quick with the few minutes I have left. I refer to this as domestic collateral damage. Can you go to the next slide, Mr. Romano? So domestic collateral damage means whether the United States of America did it on purpose or they did it on an accident. We know that Cold War politics, the effort and agenda to stop communism from spreading throughout Central and South America, allowed for some form of complicit participation in allowing cocaine to be placed inside the United States of America inner city communities predominantly occupied by African American and other brown populations. And then those drugs, while they were circulating in abundance, right, a war on drugs simultaneously was actually initiated by Reagan up under the same administration. So while the drugs was coming into our community, right, at the same token, they initiated the 1980s, 1990s war on drugs. And we're going to talk about the impacts of that. But first, we're going to make clear, just in case people think that this may not be, something that's legit. One of the actual indicators, without a shadow of a doubt, there's many more, that during 1987 and 1988 investigation, the Kerry Committee reports, and this is in relation to what you refer to as the actual Iran-Contra scandal, or the Oliver North affair, right? It says payments to drug traffickers by the U.S. State Department of funds authorized by the Congress for humanitarian assistance to the Contras, Nicaragua, counter-revolutionary organization, in some cases after the traffickers have been indicted by federal law enforcement agencies on drug charges, in others, while traffickers were under active investigation by these same agencies. Understand me, these were actual thousands upon thousands of tons of actual cocaine that they're talking about when they say under investigation and or are currently being indicted for those charges. So again, this is real. It was being allowed into our community. Next one. Now, once the drugs were being allowed into our community, what you have to understand is that the African-American male and the female, the family, was living in poverty. Post-1970s, right, you had a case where individuals are literally scrambling to figure out what direction they're going to go post the actual Black liberation era, right? There was a lot of youth roaming around in the streets with a lot to do. So gangs became somewhat of a phenomenon. But the gangs in the 1980s, right, in comparison to the gangs today, if you took 10 individuals, you line them up on a wall in the beginning of 1980, and you actually frisked them, the police, and you would check them for guns, you may have one individual with a revolver in his pocket, and maybe in the bushes, there would actually be access to a 12-gauge gun on average, right? Once drugs were made available to them, crack cocaine was made available to them, and the people that was buying it wasn't the rich folks, these were the common middle-class people, these were the teachers, these were the doctors, these were the actual pastors, these were the deacons in the churches, these were the actual school custodians. These were the people buying the crack cocaine because freebasing was cool, and the kids and the young people were actually selling it. A power dynamic shift. So not only do you have a lack of actual respect for your elders because now your elders is coming to you in complete enslavement to this particular addiction, but on top of that, you now got guns. And not only you have guns, you're now grouping necessarily medicated. Oh, wow, time off. I'm gonna get it though. It's not predicated on just having, go back to that slide, it's important. Not just predicated on having this type of geographical type, I'm from this neighborhood, you from this neighborhood, we're gonna get in an argument because we had a situation at a party, so we may go have a fist fight, somebody may get shot, it may escalate. No, it's different. There's an economic incentive. Please go back to the next slide, the slide behind. The economic incentive created a more escalated level of violence, interpersonal violence. And at the same token, you had the United States of America war on drugs. Look at 1980s, you only had 500,000 people in prison, 500,000. By actual 1990, you're talking about 1.3 million. That's over double. By the 2000, you're talking about 2 million in prison. And since then, 2.5, 2.8 million in prison. What does that mean when you take a person, a whole generation potentially, right? And you put them in the most violent place in America, right? The most traumatizing place in America, and then you send them back into their communities. What happens? Next slide. We're talking about structural violence, y'all. Structural violence that actually perpetuates and creates circumstances for enhanced and increased exposure to interpersonal violence. What? In the left-hand side, you see the drugs. From the drugs, you see an increasement of a certain type of culture and a mindset that actually evolved inside of our communities in the 80s that was never present prior to then. This gang culture, a different type of monster, a different type of creature, right? Then you have the mass incarceration, the war on drugs that actively took place while the drugs were being put in. That took populations from 500,000 to 1 million within 10 years, from 1 million to 2 million within, within 20 years, right? And that incarceration takes that trauma and that toxic stress, and it puts it back into the actual community, where geographically they can't live certain places because legally I can tell you can't be in my home because you have a felony. And economically I can tell you can't get a job over here because you have a felony. So it puts them right back into the same environment. And that environment is where our babies it's where our women, and it's where our elders exist. In that same environment, because of the actual crime that's taking place there, there's justification for businesses not to invest in that environment. There's no investment inside the schools. There's food deserts. So now you're talking about this various components of determinants that's creating toxic stress. And how does that relate to a public health crisis? Well, toxic stress is like acid. It eats up the central nervous system, which creates enhanced cases of actual mental health and other type of unhealthy health behaviors. It also eats up, like acid, the actual immune system, which then makes these populations vulnerable to chronic disease like heart disease, diabetes, hypertension, and obesity. We wonder why it's a public health crisis, right? It's a public health crisis because in the system, there's still this behavior that at some level allows for us to treat certain populations more inhumanely than we treat other populations. Allows us to get access to resources to certain populations more so than we allow them to come to other populations. And that is a problem. I'll close with that. And just to be clear, that kind of brings us to this conversation now where APHA, right, and various other entities across the country is bold enough to be able to say that systemic racism is a public health crisis and that violence is actually a public health issue. It needs to be addressed. Well, we have the background now. There's no question that the things that's been mentioned is factual, but now we have an actual policy that's action oriented. And this is what we want to introduce to you guys today, what that policy is and how we can advance that policy. Is Ramana still on the call?
Thank you, Abdullah. I'm here. So I'm going to talk about what Abdullah just provided to you as a background of structural violence that goes on in our society, created from structural racism that takes place. And violence is what is happening in our communities and within our systems. And so American Public Health Association has two different policies: racism and public health crisis as a late breaker on October 24, 2020, and violence as a public health issue in November 2018. These are responses to the kind of problems that we're having systematically and historically within our country that traumatizes the most inequitable communities that are oppressed and traumatized. 231 cities, counties, and other governmental leaders have declared racism as a public health crisis as of August 6, 2021. However, there was no strategy that was identified, no comprehensive strategy. There are siloed strategies in place, but there is no comprehensive strategy in place to address racism as a public health crisis and violence as a public health issue. So our section came in and said, this is a policy that identifies a policy gap, which is asked in the policy proposal, what is the intent of this policy? So we came out with our policy statement with the history of community health workers, which will go into a little bit more, a strategy to address racism and violence as public health priorities, community health workers advancing racial equity and violence prevention. I'll pass it on to Abdullah.
So one of the things we want to talk about first is this concept or this term you're going to hear being presented inside of our policy called HOPEIs, historically oppressed and other people's experiencing inequities. And I just want to make clear before, and it's going to spell it out let me just define what it is, right? So historically oppressed and other people's experiencing inequities means specifically historically oppressed peoples who were brought from Africa and enslaved in America. That's first population. It's brought from Africa and enslaved in America. We mentioned that. And indigenous First Nations whose lands was colonized by Europeans, including descendants of these groups who trace their genealogy back to indigenous Mexicans, Aztecs, Mayans, and Incas, etc. What does that mean? Anyone within Central, South, and North America who have lineage of people that was here prior to Europeans coming here and occupying these lands, dominating and exploiting these lands, right, is considered to be First Nation indigenous people, right? Now, there's some within the Latinos communities that more align themselves with their colonial roots, right? Whether it be Spanish or Portugal, that's okay, right? It's defined as conquistadors, right? And maybe you have a mixture of the two, and that's okay as well. But if your lineage goes back to those people who have their lands taken, and your lineage goes back to those people that actually was enslaved and brought to these lands and enslaved, you're considered to be historically oppressed. Meaning since the beginning of this history, this country's history, there's been a persistent exposure to oppression. And then we're recognizing that there's other people's experiencing inequity. So we're not ignoring other people, right? We're acknowledging that other people matter. We're acknowledging that other people's crisis is also a priority, right? But it's not more of a priority always. It's not always more of a priority than the historically oppressed. These are people that needs to be supported and needs to be advanced when it comes to what their current condition is based off what they experience. who are the actual other people experiencing inequities, right? So inequities are primarily a consequence of systemic racism and other unhealthy practices within the dominant culture existing within America. So we define systemic racism as a form of actual structural violence. There's many different types of structural violence. You can have classism, you can have sexism, you can have racism, etc. Right? But we're pinpointing the very specific one, racial structural violence, right? It's a form of structural violence that's kind of represented inside of a racial type of sentiments, right? Now there's other types. Those other types also falls in the category of other people experiencing inequities. Again, why is this important? Between the historically oppressed populations, African slaves and people that are indigenous people here colonized, one of the first things that was taken from us was our actual human dignity is having the right to define ourselves. Who we are, where we come from, our lineage, our religions, our language was stripped from us. In order to dominate the population, to take all the resilience from them in order to dominate them. So the things that connected us to our actual, our resilience, the things that connected us to our courage, it was taken from us in order to enslave us and dominate us. And to this day, those two populations, right? And I have roots within the actual indigenous populations in North America and inside Central America. And I have very strong roots within the African American community, having a lineage going back to Africa. And I can tell you, both populations are struggling with defining themselves. What we're saying is that as we struggle to define ourselves, we think about what we are and what we're not. Others should not be officially and academically defining us. They should not be telling us who we are. This concept of BIPOC is cool, right? Right, you know what I'm saying? Black, indigenous, and other peoples of color, that's cool. But it's not sufficient when it comes to actually avoiding the colonial practice of defining other people. Some people don't see themselves as a color. I don't see myself as a racial grouping. I have a very legitimate, well-established ethnic lineage that goes back to a civilization that pre-exists me being brought here to the United States of America within the Balados lands of West Africa, right? I recognize it. I'm trying to retrieve that. You're not gonna just call me black, right? Some people don't want to just be called Latino by a language. They want to be called very specifically by the roots that they connect to. Let us figure it out. And when we're talking about ways to actually navigate and address some of the inequities in our society, describe the condition that these populations of people have been hurt persistently since the beginning of time of this country to now. Prioritize them, and then we're saying that there's other people experiencing inequities. What are those inequities? Who are those people? And let's go support them. We have to get beyond defining people and allow them to define themselves. It's a colonial practice to try to define people.
So going into the strategy itself, we wanted to define community health workers. Many of you, most of you are community health workers or very strong community health worker allies. But for those of you who may not know, according to APHA, and this definition comes from the CHW section, a CHW is a frontline public health worker who is a trusted member of and or has an unusually close understanding of the community served. This trusting relationship enables the worker to serve as a liaison link intermediary between health and social services and the community to facilitate access to services and improve the quality and cultural competency of service delivery. Abdullah.
So real quick, we just want to make the connection regarding community health workers, that community health workers emerge from this natural type of organic process where when something is not working, when something is failing, right? Naturally, us human beings, we step up and we begin to actually fill in those actual vacuums and those voids. And that's been happening since the beginning of time. And it doesn't necessarily always happen with inequity. Sometimes it just can be a lack of resources, right? Poverty, period. And it's always going to be that human being or two that pops up and say, I can help you, that has that extra solution. It's always going to be that auntie or that uncle. But as it relates to the history of our country, right, you know what I'm saying, community health workers, the concept of community health workers, the concept of promotoras, the concept of community health representatives, the concepts of this type of workforce that do these very specific activities, right, emerged first in the 16th century, all the way into the 1950s and plus before they start naming them within HOPEIs communities. So whether it be people that were enslaved and brought here, or whether it be indigenous populations, right? If you was actually being dominated, then that means the people who dominated wasn't concerned about your health and well-being. There wasn't a health system that prioritized your well-being, right? There wasn't a health system that concerned themselves about your children being born. There wasn't a health system that concerned themselves about you becoming sick. So naturally, these individuals inside your community emerge and began to support, whether it be, now we call them midwives or doula. At that time, there was just the actual, that auntie or that uncle, that person that we knew we can go to, right? And that's been happening as an actual source of resiliency within our communities, like it happens all around the world, like it happens within European countries as well too. When they have those deficiencies, people step up as a human phenomenon. right? But from the 16th century all the way to the 1950s, this was happening unrecognized and unrecorded. There was no, it was like taken for granted. It was in the late 1950s going into the 1960s that you begin to see outreach worker programs emerging. Once you started noticing a level of actual research and observation of the ways in which community health workers, or the people who do community health work, how they was navigating within HOPE communities, right? People started noticing that some of these programs are working, man. This sickle cell anemia program that makes, testing available to all their community members for free. The breakfast program for free. This war on poverty, man, where people are getting access to food, whether the government gives it to them or not, we're gonna give it to them. Right? This campaign for that. The collaboration and coordinations between churches to make sure that people have their basic needs. They start noticing that and they begin to want to give a name to it. They begin to want to fund it. They first came with names like outreach workers, community health representatives, right? But the point was they began to recognize it in the 1960s. It was in 1968, right? Because again, go back to the 1960s, they also started eliminating some of these organizations that was running these programs because of the COINTELPRO objective, right? Because they identified them as actual political dissidents and unpatriotic. So a lot of those programs got eliminated, not all of them. But the actual profession that emerged, right? The title they gave them first to get first recognition was the community health representatives. And you see in 1968, that National Association of Community Health Representatives was organized and became one of the oldest in the United States of America CHW history, right? Now, as far as association, that was like some form of recognition. But how they interact with the community health representatives were telltale. It was created and put into a position, a particular bottle, and restricted, right, in terms of what they do and how they do. Right. So it wasn't into, and then, you had also the community health lay workers, right? That also was still evolving, the outreach workers, they were still doing their thing, the community health representatives. There was a different type of tone between the 1960s going into the 1970s. The relationship between health systems was very, very one-sided, right? And it was oppressive. But then in the 1980s, something different happened, right? A number of promotorial programs emerged in the United States of America, North America, because of the CHW programs that was actually very vibrant inside Central and South America, that was actually emerging within Civil War, right? It was a different spirit that came into the United States of America once the promotores, the Latino communities from the Central and South America came and started actually pushing programs for themselves, right? Farm worker, right? And when they brought that energy, right? It created this dynamic where the people that was connected, the community health workers that was connected to the systems and the ones that was on the ground, it was a mutual type of momentum, and they started to have to negotiate to figure out how we're going to advance this profession together, because we can't do it divided. So in the 1990s, right, there's a lot of people in this call that participated in it. Dr. Noel Wiggins, I can name some others and whatnot. I know for sure she was present in that. Darrell, who's currently now a founding board member of NACHWA. There's a couple other people, right, that was involved in the actual process. If y'all remember the names, go ahead and name them inside the chat, please. They had a conversation, right? It was a National Community Health Worker Advisory Act was introduced into the U.S. Congress. It did not pass, but it served as a coalesce and a constituency of support for CHWs. How is that possible? Well, it was in 1996, I believe, that the actual term CHW was coined. It might have been between 94 and 96. And it was in a gathering that took place. And one of the things I've been told from first-person presence was that the reason why CHW was actually named was because it was something that nobody else previously had pretty much took ownership of. They all had their own angles, right? Promotorials, community health representatives, community lay workers, health lay workers, outreach workers. And the CHW thing was like, okay, well, since nobody's, how about we all just attach ourselves to it while maintaining our own autonomy? So if you notice earlier, Sister Denise was mentioning the midwives and the actual peer support specialists and all the different promotorials, and she's naming all these different names and whatnot. All this represents this community health workforce, a community health workforce that define themselves. Community health worker becomes the term that allows us to push political or push initiatives forward to help us support all those entities, Anyway, 2009, the Bureau of Labor created a standard occupational classification for CHWs. 2009, again, CHW APHA section passes the definition for CHWs nationally. Then in 2011, same section, APHA CHW leadership and training policy was pushed. 2015, common indicators emerged, was something you need to pay attention to, because it's talking about being able to secure indicators and be able to make sure that you get the actual deliverables and be able to measure deliverables that you need for CHW interventions in order to actually get sustainable payment for your programs, right? And they're teaching CHWs how also to be researchers, a very profound initiative, as well as in 2019, as our sister just mentioned, the National Community Health Worker Association emerged, which we're very excited for all that's to come as that organization continues to evolve. This is a brief history. Again, the main point is that CHWs emerged from the crisis that HOPEIs have been experiencing. There's no difference then than it is now. Only thing that can be different is how we optimize the opportunity of those particular professionals. Is this me still?
Yes.
All right, so in terms of framework, right? So you're gonna see two things. You're gonna see this policy seeks to advance anyone who's a community health worker in racial equity, to advance anyone that's a community health in the actual science of preventing violence, right? So all the programs you have and all the efforts you're doing now, if you're preventing violence and you're addressing racial equity, this policy is designed to uplift you and to support you, right? And actually propel you forward. But within that, there's also some very evidence-based strategies that we're trying to put forward. And that evidence-based strategy is based off the community health worker and violence prevention model, right? It has some basic frameworks. It's the community health worker as an intervention to address structural and social determinants across the social ecological model, the social ecological framework. So us as individuals, we can step in, we see that there's a housing issue, there's a food issue, there's a health issue, there's a particular issue with violence, whatever that issue is on the structural systems level or within the actual community individual level, the CHW can be actually deployed as an intervention, right, to reinforce and build protective factors within those determinants related to health at every level of the SEM, the social ecological model. That's the baseline framework, right? We have some existing strategies that we're leaning on and we're directing our attention to be able to actually advance as evidence-based strategy as it relates to community health workers and racial equity advocates and community health workers and violence prevention professionals. Again, right? If you're doing any work in racial equity, right? If you're doing any work in racial equity and you're a CHW or you're a CHW organization, we want to support you and advance you in that. Same prevention, we want to support you and advance you with that. But our particular component we want to encourage most people to grab a hold of as well is this concept of the actual SEM, sociological model, structural social determinants of health in relation to CHWs and their intervention. And the SEM considers a complex intersectionality between the individual, community, organization, and the societal factors to understand the range of dynamics that put people at risk for racism and violence or protects them from experiencing or perpetuating racism and violence. Again, that's our baseline framework for REAs and VPPs. I reiterate, but we're encouraging all CHWs and trying to uplift all CHWs addressing racial inequities and preventing violence. And you'll see that spelled out here in the policy as we move forward into like evidence-based practices. Just to be clear, before we go into the evidence-based practice, in the policy proposal, we was required to actually first give an actual rationale, a summary, a rationale for consideration. You've pretty much been getting most of that up to this point, right? My whole spiel about history talks about, you know, saying a rationale for consideration and the problem statement, right? What is the problem? And in addressing the problem, right, we had to understand that we identified that community members coming from these HOPE populations have experienced deep levels of perpetual and persistent inequities, and they need to be supported in two areas: systemic within the structure in terms of actual racism and those unhealthy type of behaviors that hurt us because of the racist bias, as well as the interpersonal violence that happens amongst ourselves because of the actual social insecurities that exist on the individual and community level, right? Our argument was that not only is there need to be intervention to actually support those populations, but CHWs themselves who come from those populations need to be supported. You can't be a group of individuals that come from intimate relations with people who've been suffering and having challenges of getting access to health and getting access to resources. You can't come from those populations of people. Get trained as able to speak language just as effectively as any other professional, and you'd be present for 60-something plus years, and you're still having to grapple with this fact, as Sister Denise mentioned earlier, being recognized and respected as actual professions, as a professional. That in of itself is a form of oppression. So we're also highlighting the need to actually mitigate the harms that CHWs experience as the actual workforce. And when we start talking about the actual evidence-based practice, that's the actual problem statement, right? The need because of COVID, the need because of just what's been happening in our country. We need to make sure that the resources get to the people who need the resources. We need to make sure also that certain policies and certain practices within organizations get change in order that that's stopping those resources from getting to the people. That's the baseline. And then also we need to make sure that the community health workers who are most poised and positioned to support a comprehensive health equity, representation inside of our society, that workforce we support that workforce and avoiding and mitigating the harms of the classism and the actual racism that they experience. Go to the next one, please.
So I'm going to go into this is evidence-based strategies, right?
And this is on you, yes.
Yeah, so I'm going to go into evidence-based strategies for racial equity. This is specifically for racial equity. So what we did is broke down evidence-based strategies based on racial equity and violence. So this is the REACH program, it stands for Racial and Ethnic Approaches to Community Health. And it took place in 22 sites between 2007 and 2012. So it demonstrated evidence of CHW contributions supporting racial equity interventions. And you'll see on the side, there's some data that you can look at. On the policy level, REACH CHWs developed, advocated, and implemented guidelines for South Carolina for chronic disease, for diabetes-specific racial and ethnic groups with healthcare providers, diabetes-related hospitalizations, and emergency department visits that reduced by 50%. On the organization community level, CHWs helped to integrate social determinants into health services, where they developed and disseminated resources to families and providers, focusing on access and navigation of housing resources for clients. This resulted in a return on investment of $1.46 for every dollar invested. On the individual level, REACH CHWs provided interventions and an after-school program for kids called Kids with a Positive Attitude, where students use photo voice to demonstrate their perspectives of the needs and barriers in their communities. Another program included an after-school program in Arizona to address health disparities and cervical cancer prevention intervention for youth leaders. So what I want to say also from this is that community health workers and racial equity work have been doing this work for years. They just have not been recognized as such. And so these are some other evidence-based practices in racial equity. So Children's Partnership promotes equity and anti-racist values. Northern Manhattan Community Voices Collaborative Program hired CHWs, where they were able to help 40,654 people with health improvements. This is the policy level. Rhode Island General Law 2364.18 focus on the health workforce diversity and develop using a health and a policies approach, where CHWs were leading that. I'm part of that group. My colleague Danny Ritchie was part of that work. Commission made recommendations for the coordination of state, local, and private sector efforts to develop a more racially and ethnically diverse healthcare workforce, lifting up CHWs. And we are asking that health and all policies be used as an approach in implementation of this policy proposal on the state and regional level. Abdullah, this is good.
So again, one of the things we have to do with the policy is we have, and again, just to be clear, we had an opportunity where we was trying to get approved late breaker, and we really scrambled to make that happen, right? And it was really a blessed opportunity because we got a lot of feedback and we had a lot of assistance and help. Dr. Noah Wiggins, Dr. Williams, Dr. Danny Ritchie, and various other individuals, man, we kind of honed in and started thinking about, what can be done to make the actual policy better. Right. And what we realized was that, we had a lot that we were trying to put out there because there's a lot going on with this particular issue. So this particular round, we was able to kind of hone in on two major evidence-based strategies. She just mentioned REACH as it relates to actual racial equity. And then I'm highlighting the STRIVE program as implemented in 2011, 2016 from the Multnomah County Health Department, striving to reduce youth violence everywhere, CDC funded initiative. Right. And it's just this to note that this particular actual strategy actually integrated CHWs into it. And this is by the leadership of Dr. Noah Wiggins, right? She integrated CHWs into it. She integrated community-based participatory research. She integrated popular education into two existing evidence-based strategies that looked at youth leadership development and looking at the built environment, right? So this is really a unique adaptation of the 4 demonstration sites that took place within the years of 2011 and 2016. This location in Multnomah County only had those 3 additional components: popular education, community health workers, and community-based participatory research, right? And in practice, because I happen to have been there, the leadership, herself and Sister Rebecca Stavenjord, was very equitable in allowing myself and Dr. Dwight Merritt to be co-leaders inside the process. So we was able to lead as community health workers from the actual beginning to the end of the process and be able to engage not only within communities on an individual level, community level, but also engage within organizations, doing trainings within schools and trainings within organizations, as well as influencing policy. And we'll go over some of that. But one of the things before I want to mention to you is that right now, just recently, we don't know the exact date for it, but Dr. Colleen Barbero from the Department of Violence Prevention, right, and a group of other professionals, including Dr. Noah Wiggins, Dr. Ashley Winterstrom, there was Dean, can't think of Dean last name, I apologize for that, but he's actually a actual credible messenger that also identifies himself as a community health worker. The other CHW that was a co-author on the actual lit review. But understand this, as it relates to violence prevention, 300 articles reviewed, 20 programs identified, right? Looking at ways in which the community health worker profession and violence prevention has already established itself and opportunities for it to be expanded. That's been accepted for publication by the Public Health, what is it, American Public Health Journal, right? And American Public Health, is it Health Journal, Ramona? APA?
American Public Health, Journal of Public Health.
Yeah, American Journal of Public Health, right? So that's coming out at some particular point. The STRIVE program is highlighted in that program as it relates to 2011 and 2016. What's also noted is its adaptation, which we're going to talk about as well too, which was taking place here inside Wilmington, North Carolina. So again, on the policy level, the 2011-2016 Multnomah County Health Department STRIVE program, CHWs participated in planning for the countywide comprehensive gang assessment and partnered with the City of Portland's Office of Equity and Human Rights Black Male Achievement Steering Committee and led efforts to discontinue the use of Portland Police Department's controversial gang list. That was a critical achievement. We forced them to look at it from a public health lens, and instead of tracking people who have never committed crimes, tracking people that was as young as 13 years old on their gang list and using it for criminal investigations and using it for actual gang enhancements, we got them to actually shift and say that they can track people with violent crimes. And by tracking people with violent crimes, then they can categorize them, whether they're involved in gangs or whether they're involved in other drug rings or whatever the case may be. But that would have took that list from actually predominantly being African-American, right, to actually being a little bit more equitable in the type of people that's really involving themselves in violence in our community. So that was a really major success. On the organizational level, CHWs led the adaptation of a 90-hour CHW certification curriculum with the focus on violence, which resulted in the training of 27 community health workers in violence prevention from various organizations across the county. It was an excellent training, beautiful people, co-facilitated by the whole Community Capacitation Center team, as well as the STRIVE team. Individual and community level, CHWs led the recruitment and training of the Youth Empowerment Solutions program. So we got out there and actually engaged the people on the ground at all 4 demonstration sites for year 1 or for year 3. And then by year 2, I believe it was like 9+ actual sites. That may not be the exact number, but it was definitely an scalability of actual sites beyond the original 4. We connected with those families, we supported those families, and we supported the youth in the program, right? So it was direct engagement on that community individual level. But we also develop and facilitate a year-long training for teachers and staff titled Building Resiliency Through Relationships in an Educational Setting. That was in response to a couple people being shot on school campus during the time that we was implementing our strategy. So we was able to actually engage the teachers, the staff, and the actual students in thinking about how to rebuild trust and how to build resiliency inside the classroom in order to stabilize the day-to-day activities from a standpoint of from the time I enter into the room to the time I go out. And again, CHWs led and developed that particular training. Next slide.
Hi, Abdullah. I'm sorry to interrupt, but I just want to do a little brief time check because it's almost 5 o'clock, but we do have until 5:30. So I hope that everyone stays for the discussion. And so start thinking of questions and stuff you want to discuss and type it in the chat. We'll have a good discussion. Sorry to interrupt.
Awesome, thank you. Yeah, I'm gonna speed this up to make sure that we can actually get to the Q&A. So again, that program is being adapted inside of Wilmington, North Carolina, Socorro House. I see a lot of representation on the actual call right now. We have the CAFEAR Comprehensive Community Violence Prevention Strategy. That's the first demonstration of what is now referred to as a community-based public health response to violence. Again, that's myself taking that STRIVE model, being a part of it from the beginning to the end, having the actual thumbs up from Dr. Noah Wiggins, watching everything that's happening, seeing the fidelity of what's going on, and being able to implement that here in Wilmington, but doing it completely opposite to what happened with the CDC. The CDC took it, put it into the health department, then put it into organizations, then put it into the community. We're saying that we're taking the model, comprehensive, CHWs leading from the beginning to the end, moving it from the community into organizations, back up into the system, and keeping a bi-directional relationship with the two. Other actual violence prevention programs that have CHW activities is the Cure Violence Program, as well as the Health Alliance for Violence Intervention, HAVI, hospital-based as well as hospital-connected model. Both of those are community health workers in activity. They don't all identify themselves as community health workers, but there's many people within the workforce that are starting to actually migrate to being a community health worker as a public health professional, because there's more protection, there's more support, and there's an actual advancement happening within that. We're hoping to encourage that process. But both of those programs are very well-established evidence-based programs where they take community health professionals and advance violence prevention.
So next we'll go into action steps. This is one of the most crucial parts of the policy proposal, to make sure that our action steps are aligned with the problem statement and the evidence-based strategies. So on the policy level, and we wanted to make this very clear too. So whatever APHA does, we have been told, I serve as one of the chairs for all of the APHA co-chairs among all the sections. And one of the conversations we've had with the other co-chairs to make sure that sections know that when you're implementing a policy, when a policy gets passed through the section, it's not enough. There has to be work on the grounds, which Brother Abdullah had talked about. So on the policy level, these are a few of the recommendations we've provided, and you can see more details on the policy proposal in the link that Angie had shared earlier. So equitable partnership with CHWs to implement a health and all policies approach to address racial inequities and prevent violence, increase funding for CBOs for community-based interventions in racial equity and violence prevention, e.g., in other words, CHW REAs and VPPs, increase funding to organizations to employ CHWs trained in racial equity and violence prevention. On the organizational level, encourage and incentivize employers to participate in racial equity trainings designed to foster healthy environments for the CHW workforce. We're actually, the APHA CHW section is having a summit in November 2022 coming up, where it's informed by RWJF health policy research, scholars dissertation work, and we'll be launching that flyer soon, so people can register. Encourage and incentivize employers to hire CHWs or program managers and supervisors who have been trained in racial equity and violence prevention. Integrate principles of CHW culture and racial and health equity interventions using popular education pedagogy. Partner with CBOs to train and hire CHWs to lead racial equity and violence prevention, and promote implementation of the CHW Common Indicators Project. And I wanted to make a shout out to a couple of partners. So on the policy level, Partners in Health is doing profound work when it comes to supporting community health workers. APHA CHW section, as you know, has passed policies. NACHWA has been doing policy work as well, and they have a policy platform, and Angie has been a part of that, doing great work with them. Community-based Workforce Alliance around COVID vaccination. On the organizational level, APHA CHW section with the summit coming up, Center for Community Health Alliance, North Carolina Office of Rural Health, Department of Health and Human Services in North Carolina CHW Association, supporting racial equity trainings, North Carolina AHEC as well, El Sol in San Bernardino, Cure Violence, Global, and HAVI.
And also remind, there's a question about the actual the summit in November, so if you can respond to that, maybe share a link inside the chat.
Sure, I can do that.
So as far as action steps on the community individual level, so keep in mind you have, to me, individual community is interpersonal, intrapersonal, right? It's still whatever happens in the community, whatever happens in the family is happening between individuals, right? So it's still more of that interpersonal type of component. We're calling all these great, huge organizations from the White House to all type of other entities that's out there on the national scene to increase the awareness of funders, right, and other organizations for the need to support disenfranchised CHW programs within CBOs. Right, and also to advocate capacity building for CBOs where CHW, specifically CHW REAs and VPPs, can be trained and deployed to foster collaborations and productive partnerships between CBOs and health systems. Increase funding to support CHWs, REAs, VPPs, interventions to strengthen structural and social determinants of health within HOPE communities. Include CHWs in the participatory research guided by equitable collaboration to support research priorities identified between CBOs, health systems, and the academy. Fund health promotion and community organizing campaigns to build racial harmony, shift and to shift behavioral norms around interpersonal violence within HOPE communities. Again, these are actual calls to system level, organizational level to support these initiatives on the community level as it relates to CHWs and CBOs. We also have on the individual level, we get more intimate and person to person. We're talking about fund CHWs and racial equity and violence prevention to address disproportionate exposure to multiple forms of violence and other adverse structural and social determinants of health for individual and family case management utilizing wraparound services model. Fund CHWs and racial equity and violence prevention to build resiliency and support healing among individuals and families affected by ongoing historical trauma. Recognize CHW and racial equity and violence prevention to do two things. One, support equitable reporting of implicit bias and racism experienced by community members when interacting with healthcare institutions and other social services. If you're dealing with a client, man, and they're going through something as a CHW, we should be able to actually have some form of accountability or some type of way we can actually hold these health systems accountable for, or individuals within these health systems that for misrepresenting what supposed to be the goals and objectives, which is comprehensive health for all. How do we hold them accountable? CHWs can help with that, right? Support and advocate for community members experiencing implicit bias and racism while navigating institutional environments. So these are the primary action steps across the levels of the socio-ecological model, Ramona.
So we're going to go into
next steps.
Next step. So it's great. It's 5:03 and we're good. So I was a little worried about that. We're actually really good on timing. So endorsements and implementation. So we have a Jamboard link that Angie is going to put into the chat. So some of you saw the external endorsers that we have. Partners in Health, North Carolina AHEC, North Carolina CHW Association, CHW Common Indicators Project, CHASM. So we have a good deal of support, but we're looking for more endorsements because what happens is when they see external endorsements, when we go to the public hearing, and there will be a public hearing in November for this policy proposal to get passed, where we'll be questioned by the chairs and other sections about this policy proposal to get passed. At that time, it'll be really important, and even before that, to show who the external endorsers are. So the more we have collaboration in that, and advocacy among external endorsers, it'll be a stronger policy proposal for the internal sections as well. And I'm going to hand it off to Abdullah to talk about implementation.
And I also want to add, whether you're part of an organization, other organizations, share this information, man. It's a part of history being made right now. We want to be a part, all of us here in this room right now, everyone that is connected to this work want to be a part of history. And these are some very bold statements that was made in 2020 when systemic racism was declared as a public health crisis. Bold statements when 2018 violence was identified as a public health priority or public health issue, and they identified issues of systemic racism or other forms of inequities as a reason why that violence exists. Those were historical moments, but those are actual policies that just gave information and handouts of papers. This is a policy that's calling to action. This policy means nothing if we don't act on it, right? So endorsement looks like also the buy-in. We want as much of a collective buy-in as possible, right? I do believe without a shadow of a doubt that there's power in the people if the people believe that. If the people really believe that, right, that there's power in their constituency, what they represent as constituents, then it matters and it begins to matter. And we see it happening all across the country. So endorsement is just more than, hey, we want to help the people that's going to make the decision to say yay or nay on this particular policy. We want to help convince them. Endorsement is also about you involving yourself and being engaged and being a part of this moment. So we encourage you to do so and encourage your organizations to do so as well too. When it relates to implementation, again, it's twofold. In one sense, we're talking about a very fluid, very expansive type of implementation that looks like any CHW program or CHW profession that's doing racial equity work, right? We want to be able to support you in creating trainings. We want to be able to support you in creating models, right, of how you deal with racial and address racial inequities. And same thing with violence prevention. How do you understand yourself doing violence prevention work, whether it be domestic violence, whether it be sexual violence, whether it be human trafficking, whether it be child molestation, whether it be actual gun violence, whether it be whatever the type of violence it is, right? If you're a CHW and you engage in that work, we want to support you as a CHW to be able to secure funding to do what it is you do in the space that you do it best with the community, right? Now, that's very fluent and very expansive. You're going to be able to develop your own evidence-based strategies within that, with the support of the organizations and partners that you have. Then we have a more concentrated scientific process where we're literally trying to advance, a comprehensive strategy, right, to incorporate CHWs to be able to navigate across all levels of the socio-ecological model to address structural and social determinants of health. There's already evidence that's backing it. There's publications that's backing it, and the work is already happening. And we have some partners already that's supporting us, right, that's actually buying into this particular model. We need other partners and we need other organizations, we need other entities that's interested in supporting those type of evidence-based strategies in relation to REAs, racial equity advocates, and community health workers, bias prevention professionals. Again, twofold. So again, reach out to us if you're interested in either one or just being a part of the team and connecting with us.
Yes, and I wanted to say one more thing really quickly. So I saw a question for the the APHA CHW section summit, CHW Racial Equity Summit that's going to be taking place November 6th and 5th, and the 6th, it's going to be 2 days. We will send out that flyer within the next 2 weeks for registration. Would love for you to attend. It's open. And it's going to focus on addressing internal equity. How do community health workers have internal equity within institutional settings in order to uplift capacity externally to serve the HOPE communities? And that's based off of RWJF work that we've been working on. Angie has been a part of the co-design team, Abdullah, Dr. Danny Ritchie, Sergio Matos, Dr. Noel Wiggins, Tede, Eric Bruno, and I think I've said pretty much everybody who is a part of that co-design team. Evan Richardson, who's on that team, has North Carolina AHEC supporting us as well. And so I'm just giving a shout out. We'll make sure that's sent out so you all can get that and register. But thank you again for your time and for this opportunity. Please provide questions at this point. And if you have any, if you'd like to reach out, you can email us at admin@chasmnetwork.org. And we'll go into questions at this point, and I'll stop sharing.
All right. Yeah, I mean, I don't know if you guys have been seeing Ramana and Abdullah getting lots of love in the chat, and thank you everybody.
So love you guys. Thank you guys.
Love you guys too. We haven't seen it, but thank you.
So much love in this room right now. And okay, so a lot of folks are over in the Jamboard, and I don't know, would one of you be willing to share your screen? That might be easier, so I can kind of go back and forth between where I've got notes and stuff.
Sure, Angie. I have the Jamboard up, so let me go ahead and share.
So far, the most common, the most asked question that I'm seeing so far is like, how can we support this policy, and what would endorsement mean? Yeah.
So endorsement, it looks like you have to get your organization, whoever's the decision maker within your organization, we want it to be an organization, or it can be a coalition, that's a well-established coalition. You need to have that leadership, ideally participatory, because you guys represent a larger population of people, whether you're, a nonprofit organization or your association or your coalition. But it'd be nice if it's participatory process, and you're basically saying that after reading the actual policy, this is something that you support. This is something you want to see pass. It's something you want to see, advance within our actual country. That's one of the main ways that I think endorsement, that's probably the only way endorsement can actually happen, right? Or if you know people within APHA that sits within certain sections, you can bring their attention to the actual policy and say, hey, have y'all section taking a look at this? What's your opinions on it? This is my thoughts on it, right? Did you know this? Did you know that, right? If they're thinking like, well, I don't know if we really, you can have that conversation with them and support them in having a better understanding of what it is they will be voting on when it comes to whether or not they actually accept or they reject this policy. So again, there's two folds. One, your organization itself that you're connected to, coalition, association, whatever, right, can actually buy in and actually submit their names and saying that they endorse this. We'll add you guys as external endorsers. The other way is if you know people within APHA, people of influence, or people that know people, y'all know how it goes, right? Reach out to them, have a conversation and say, hey, look, have you seen this? Is your section or your friends inside your APHA section, are they looking at this? No? Well, listen, man, you need to, have that conversation with them. That's the second way I think can be really beneficial to get that in-house type of shift in energy, man, and make sure that we're dotting our I's and crossing our T's as much as we can before that day comes where that final vote is made.
So I want to add another point. When you do decide to endorse, once you've talked to the person in your organization, CBO, and we're not only looking for endorsements from healthcare systems or institutions, we're looking for endorsements also from CBOs, from public health settings, from government settings. But when you decide to do that, please email us. You can use the admin@chasmnetwork.org, and we will send you a form. That form has to be filled out and signed by the person that makes decisions in your organization in order to get endorsed, even if you're an external endorser. So that is, you have to provide that in order for APHA executive to honor the external endorsement. So I would just add that point, and we can send that form to you once you email us that you're interested to endorse this policy proposal.
Can individuals endorse the policy proposal, Renata?
No, I
No,
believe they
They
can.
take them from organizations only.
Yeah,
but you
it's from organization.
You can send us an email and we can know you got our back. So when opportunity comes up, we can make it all happen together if you're individual.
Yeah.
Yeah.
And join our policy committee calls. There's, we're going to start talking in our policy committee calls. We meet the third Wednesday of the month. And what we're going to start talking about is how do we start implementing this policy in state and regional levels, looking at grant funding. How do we move this work forward? Whether APHA, and we're praying that APHA does fully recognize and pass this in November. It looks like they will. Whether they do or not, usually once it gets passed by JPC, hopefully it then gets passed. But we need to keep doing this work on the grounds to recognize community health workers in racial equity work and violence prevention. And when you align that and crosswalk that along the socio-ecological model, what takes place is you see a career pathway and you start recognizing community health workers in that work, which they haven't been done. So CHWs have been doing this work, but to call it out and to support them and say they have been doing this work, they're recognized as CHWs and VPPs. Abdullah's been doing this work for years in violence prevention and in REAs, puts it at a different level, on a policy level that then moves into this systems and throughout the community and on that individual level.
Yeah, one thing I'll add is all this. Just going back to something I put in the chat earlier is, if we think about the APHA definition of community health worker, which I think a lot of people know and a lot of people use because it's so well recognized, that's an APHA policy. That's an example of a policy. And so that's what we're trying to do here is create another APHA policy that's like, hey, to anyone who needs to know, or doesn't already know, community health workers have been doing this work in racial equity and violence prevention. And so I think, if I'm a CHW and working and my employer is like, why do you need to go to this committee? Or why do you need to, do X, Y, and Z? And you're going to be out of the clinic and, trying to challenge me on some of what I'm doing in my work. I would maybe offer this policy as something to say, this is in my scope of practice, doing community organizing and advocating for health promoting policies. And so it's just another tool to have in our toolbox when we're advocating for ourselves and each other as professionals.
Absolutely. So again, the uplifting the common indicators work, and then which is obviously a lot of leadership is connected back to the C3 roles that came out that everyone recognized, which actually crosswalk. If you look at them, they crosswalk across the socio-ecological model, right? But then also uplifting, again, that CHW definition from the APHA section. These are all defining moments, right? Defining, activities that's happening. But the other piece that comes along with this is that in the policy is also addressing this fact that this CHW workforce, the challenges that it's been going through in order to be recognized and to be supported, it's not just hurting the CHWs. It's not just hurting the actual Hopi communities. It's hurting our whole society as a whole. There's people in positions of influence and actual executive directors of actual health systems and other type of actual systems, right? That genuinely want to see change, that genuinely want to actually shift Americans' narrative and actually make sure we're doing what we're supposed to be doing, right? But the reality is that there's still these other type of behaviors that's actually persistent, and because they're not being prioritized and addressed in a way that actually removes them or actually subjugates them to a certain degree when it comes to inhibiting the workforce, then it's still allowing us to actually find ourselves dealing with overwhelming health inequities. CHWs in of themselves represents health equity. If you can activate that and actually support that, like we see it happening across the country. Now the question is making sure that they're being advanced in all the ways that they are useful, in all the ways that they actually can be beneficial, while at the same token, a pathway is carved out for them where they're not continuously being harmed, that the same history is not coming back to haunt us. So you're absolutely right in making that comment.
And the other point I wanted to add that poor health outcomes in our nation, the root cause driver behind that is racial inequities. It's one of the root cause drivers. So when these sections endorse these, and there's other sections that are now looking at this policy proposal, law and ethics, maternal child health, to name a few of them, occupational health section, to just name a few of them, they recognize that this can shift, especially if they recognize the value of community health workers, which we laid out in the policy proposal with evidence-based practices and data, that it shifts and improves public health and healthcare, the outcomes in our healthcare systems. So this is something that has to be addressed, not only internally, internal equity for community health workers, but in external equity for all our communities. And we saw that. We saw the effects of inequities, racial inequities, and how our communities died during COVID, and how that was spread to other communities who aren't as oppressed during COVID, and what it means not to have preventive upstream care led by a group like CHWs.
Absolutely. So I kind of want to open it up and ask the participants who are here still. There's 104 of you still here after 5, and I feel like that speaks volumes. So to those of you still here and engaged, what do you think? What are some ways that you might support this policy or help advocate for it and implement it on the ground? What are your ideas? And feel free to just come off mute. It's really hard to see if anyone's raising their hand from when the screen is being shared, so just chime in. You can also just add it to the chat, whatever feels best for you.
The question is, there's a question, will the policy be translated? You know what? I'm excited to support any effort if someone wants to help us make that happen, but 100% we would love to actually, I'm gonna say not love to, I would say it would be a necessity, right? Because again, and I believe APHA will, I believe it's the 150-year anniversary. I believe that there's been some really progressive policies being pushed. I believe that we're in a different time in our history. We can return back to a backwards time of our history, you know, in the next couple of years. But right now, where we're at right now, I believe that there's a ripe opportunity to lay some actual groundwork for work to actually move forward in the areas that it needs to. Again, this is real life, right? Things may not happen the way we want them to happen. Whether that's the case or not, the details of this particular policy, right? The real power in it is in the buy-in that we all see in it, right? The evidence that's behind it. The policy is supported with evidence. There's literature backing it at every particular point. This is not some fly-by-night brainstorming that people just put together. There's some very high-level professionals that then joined in a participatory process over a year and a half in time. There's organizations, the CHW section, National Association, they're backing this. So whether it's accepted or not, there's power in what the people can do with it, right? So I say that to say that we need to actually think about what would it take to get it translated into Spanish, because it can't happen without that population of people also leading, at the forefront with us. So yes, if you know somebody, hit me up, please. Our organization that's willing to help. That's my answer to that.
I just saw a question, what is the policy number? That's a great question, and I am getting that to you right now. I think that was Alicia Bell just asked that question. We are getting that over to you. I also wanted to add another point about the policy proposal. So this policy proposal falls under Group C, Law, Violence, Prevention, and Equity, and we have a little bit of time. So what I wanted to do is go ahead and show you all the policy proposal itself. And I'm gonna just log into my APHA, sorry, give me just a second, the APHA database so you all can see where it falls under public viewing. So let's see if I can do this. Okay, sorry, give me just a second.
And Ramona, at this point, is it open to like anyone, or do
you have to be APHA member to access it on their site?
Oh, okay.
Yeah, you have to.
But we have the policy though. The policy is obviously downloadable, so we can disseminate that. Again, you can reach out to us, again, admin at chasmnetwork.org, and we can get you the actual physical policy.
Yeah, we can. So this is the actual policy is right here, and it actually falls under Group C, Law, Violence, Prevention, and Equity. And this is the policy that's posted. This is the policy itself. And you can see it's got all the authors in here. And again, you have to be an APHA policy member, but if you're not, we can definitely, if you email us, we can send this to you. This lists all the other policies that have something to do with the policy that we have here. It goes into rationale, and then it goes into the different levels, and it closes off with the action steps. And this is the exact policy proposal that people can see for public viewing if you're an APHA member.
And so one last thing I think I'll say before, you know, and depending on how we move forward, but I'll say this too. It's two things to think about, right? One is that this particular policy is, make no mistake about it, is designed to actually support and help to lead addressing some of the actual historical inequities that CHWs have been dealing with as a profession and as a workforce. It prioritizes racial equity and prioritizes violence, right? Prevention. But this is about all CHWs. It's about all CHWs. The second thing I want to say is that it's also about, you know, busting out this condition type of norm where we actually look at CHWs in this monolithic type of way, right? Or as one or two different type of things that they do, right? And thinking about also how can you advance CHWs outside of racial equity, outside of violence prevention? How do you do it in the areas of actual reentry, which has already been done across the country, right? Supporting existing efforts like peer support models that's doing the mental health, as well as the substance use disorders, right? How to support those existing efforts and get them integrated into the CHW profession so we can all move as a unit, right? And not be vulnerable in the way that we are. So again, on the surface, you hear racial inequities. On the surface, you hear violence prevention. You hear these models that's coming out there in these evidence-based programs, just to get the conversation going, so we can then actually support existing efforts to address these other issues that we know exist, where CHWs are being hindered in their capacity and not being treated equitably as a workforce, and not being used, I have to use that word used, but not being optimized in all the different ways that they can support, making sure health equity is available to every citizen in the United States of America. Think big picture with it.
This is Evan.
Hey,
hi, Evan.
Sister Evan.
Nice to hear your voice.
Nice. What a great honor it is to be on this, and when, as always, powerful presentation and powerful work. And it's the right work. So glad that you guys are doing it.
Thank you.
It seems like it would be helpful to have folks not just get endorse, try to navigate shepherd endorsement by their organization, but to spread the word, like maybe even reach out through networks with a recommendation, some kind of statement why, to really encourage as many other people to also endorse, because I'm kind of picking up that the more folks who endorse this, the more likely it is to get passed through the review cycle. Is that correct?
Yes, ma'am. Absolutely. That's an excellent suggestion. So you're saying, instead of just personally within their organizations endorsing, using their networks to blast out messages and make people aware that this policy is out there and encourage them to also endorse. Is that correct?
Yeah, and I'm happy to maybe work on some talking point. Like I'd like to test something out, like craft an email and send it to you guys for review to make sure that it's
awesome.
and then maybe that can be shared with others to use and adapt.
That would be excellent. Thank you so much.
And we actually, and I did put the policy proposal into the chat, because what's going to happen is I'm going to lose emails. There's going to be multiple emails going out. So I just put the PDF into the chat. It should be the most latest PDF of the policy proposal itself. So just like Evan said, if you have networks that want to support, or your organization wants to support, you have the draft now. What I wanted to add is, Evan, thank you for lifting that up. We're actually working with Evan through the CDC grant on racial equity trainings in North Carolina for supervisors in advanced medical homes. So she has been a strong advocate, as well as Honey Estrada, who is the president of our North Carolina Association, who I have the honor of helping to chair the association with.
Absolutely. So if there's no other questions or comments or whatnot, we always love to save a little bit of time. It's 4 minutes before 5:30, which would be our actual window. Romana was so stressed out about what it's gonna be. And because I actually go, if anybody knows me, I kind of go. So I'm always like overtime a little bit. And I kind of don't really care depending on the subject of the matter, So this time I was really thoughtful. Y'all even heard my little ringer. But we made it our time, right? And Unless is it, what are your thoughts, Angie?
I just want to make sure, let's see. Okay, so I'm going through the chat and I can see, okay, the link for, are you saying there's a link to a
Thank you,
PDF where
Dr.
anyone
Noel
can view it?
No, I just put the PDF into the chat, Angie. So if
Oh.
everyone moves up a little bit, there's a PDF of the draft that I just put into the chat, and everyone can open, whoever needs it can open that up. I'm wondering too, if we want any
Great.
closing words from Denise or Ashley. And I again want to thank everybody. Thank you so much for being here. Thank you, Denise, for leading, helping us put this on a platform, and Ashley, your continuous support in this section to get this endorsement passed.
That'd be excellent to let them kind of close it out with some thoughts.
Wow. First, I just want to say how affirming it is to sit in a space and have this history brought forward. The telling of our stories is healing. It is coming together into this circle and acknowledging where we have come from and what we have been through, that helps us to articulate and bring forward where we want to be and who we are for the future. So many people are speaking right now about the future of community health workers, the future of public health, the future of COVID response, the future, et cetera, of racial health equity. And I have been so honored because you have called the names without naming them of so many of our ancestors. So I'm very grateful because there's much power in that. The other thing that I think is critical, and it is essential to NACHWA's work, is that we were launched with a vision to unify. So all the stories that you hear that are coming from every corner of the globe and all of these layers of experiences and histories do have a common thread. And so when people say that we cannot be unified as a profession, I think that Abdullah and Romana and all of their supporters have completely demolished that. And instead, they have brought a unifying story, and we need that story. I think that every CHW network and association, because we have this recording, should tell that story, because our histories are not the common story, right? Not just of one culture, one geography, one ethnicity, one experience. Yes, you can go deep in that, but all of our stories. Number two, I think that for NACHWA, we intend to integrate this into our national policy platform. So while APHA is working on adopting that policy, we can advocate from outside, and we can help to disseminate that to others who want to create that momentum. So the language has already been created, the research has already been done and articulated, and we are a member association. Number three, we can help build capacity of our members to speak about our history and who we are. So this is just phenomenal. The only other thing is I'm trying to figure out how I can just get Abdullah like on the straight speaker circuit. I just have to brother, please. Do not stay in North Carolina. I know they love you there, but I'm just saying, you're gonna have to get around. You know what I'm saying? If we got to do outside everything for COVID, the passion and the love, as Angie said, is so obvious in the work of Romana Abdullah and so many of their contributors. Thank you so much again for allowing us to share in this. Wonderful. Can't wait to see what happens. Thank you. Thank you all for coming.
Yes, thank you for your leadership, Denise. Thank you.
Thank you. Thank you so much, Angie, for all your help and work. You're awesome.
Shout out to Socorro House on the scene.
Thank you, Abdullah and Romana, and thanks to everyone who participated. Have a great afternoon. Or
bye, everyone.
in the Pacific time. All right, take care. I see Noelle is here. Ah. Hey, Noelle. Good to see you for a moment.
Good to see you too, Angie. Awesome job.
Thanks. Oh, I see an Ortwell logo too. Greetings from Oregon to Oregon.